Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of welcoming to the podcast Dr. Christianne Lok from the Department of Gynecologic Oncology in Amsterdam, in the Netherlands, and Michael Seckl, who is in the Department of Surgery and Cancer in Charing Cross Hospital Gestational Trophoblastic Disease Center in Charing Cross Hospital in London. So we're really excited to have a discussion on this very important article that was recently published. The title is The Practical Guidelines for the Treatment of Gestational Trophoblastic Disease, collaboration of the European Organization for the Treatment of Trophoblastic Disease, European Society of Gynecologic Oncology, Gynecologic Cancer Intergroup, and the International Society for the Study of Trophoblastic Diseases. This was recently published in the Journal of Clinical Oncology, and we're really very, very excited to welcome you both to the podcast. And again, obviously, lots of important topics and questions to be discussed. So welcome again, Christian and Michael, to the podcast.
Yeah, thanks, Pedro. It's great to be here.
Excellent.
It's a pleasure to be here, and we always love to talk about trophoblastic disease. Both of us.
Exactly. So we're going to take advantage of that with this podcast, Christianne. And we'll start with you. And if you can just start by providing us with the definition of what encompasses gestational trophoblastic disease. And also, can you speak as to how frequently is gestational trophoblastic neoplasia diagnosed?
Yes, well, as you definitely know, gestational trophoblastic diseases is a group of rare pre-malignant and malignant diseases, and they are characterized by their origin in trophoblastic cells. So the pre-malignant forms are the complete hidatidiform mole and the partial hidatidiform moles, and also atypical placental site nodules. We talk about that later on. Malignant forms are called gestational trophoblastic neoplasia, and they include invasive mole, choriocarcinoma, placental site trophoblastic tumors, and epithelioid trophoblastic tumors. And you ask about the incidence. That's not so easy to say because the incidence varies not only per GTD type, but also per country. In Asia, for example, GTD is much more frequent than in Europe, but we estimate that annually about 220,000 women are affected by the diagnosis, including 22,000 with GTN.
Excellent. So thank you for that introduction, Christian. I'll turn over to Michael. Talk a little bit about this particular project. Can you tell us what was the methodology and the search strategy, as well as the selection criteria to develop this important manuscript?
Yeah, thanks, Pedro. So we started actually from a background of having developed the European guidelines for management of trophoblastic disease and the tumours, which was published in the European Journal of Cancer in 2020. And we realized that those guidelines were lovely for Europe, but really weren't so great for the whole of the rest of the world. And so we teamed up with ESGO, the EOTTD, the ISSTD, and the GCIG to see if we couldn't generate a set of guidelines that would be more globally applicable. And so we asked each organization to nominate a chair. So I was chair for ESGO, Christianne Lok was chair for the EOTTD, Ros Berkowitz was chair for the ISSTD, and we had Elena Brancu, who was chair for GCIG. And each chair was then responsible for nominating a group of 12 or 13 GTD experts from their selected organizations, representing expertise across all the medical disciplines relevant to trophoblastic disease. So not just gyne-oncologists and medical oncologists, but also obstetricians, geneticists, pathologists. So you get the idea that it's a very broad group of specialists needed to manage this rare group of diseases, and representing all the continents of the globe. And then we organized a series of consensus meetings for all of these experts with the 4 chairs. 5 meetings from roughly, I think, October 2022 to November 23, most of which were 2-hour online meetings, but one of which was a whole day face-to-face and online meeting. And we, prior to our first meeting, circulated the European guidelines. We provided them with a completely new set of reference data sourced from PubMed for all relevant publications that we could identify in the English language, excluding editorials and basic science papers. So we weren't interested in the in vitro data, more what's going to affect the clinical data, and asked them to select the papers they felt were most relevant, and also to go through the references in those papers and identify any other references they thought were relevant to inform the committee as we move forwards with our guidelines. And once we had agreed guidelines, and of course, where there was any dissent, we had voting, and there had to be 2/3 in favor of a particular recommendation. And if there wasn't 2/3, then the recommendation wasn't made. But once we formulated and agreed the guidelines, then we sent it out for external review to another panel of experts from around the world, again, covering all the different disciplines. Got their reviews back, then rediscussed the feedback from the experts and made a final formulation of guidelines, which was then submitted for publication. So that was the process.
Michael, I have to congratulate you and commend you and the entire team. I mean, what an amazing achievement. And we in the gynecologic oncology community, of course, obviously, thank you for doing so. And I do have to say also, just in the last week, I have found myself actually forwarding this manuscript to several colleagues who reached out to me for questions on gestational trophoblastic disease. So really, thank you so much for putting that together. Now, I want to turn to Christianne. This question, as you'll see, says several questions from our fellows in the journal. This question is from Sofia Bigardi in Padova University in Italy. And she's asking, the guidelines propose a new minimum criteria for defining GTD centers. What are the essential elements required for a center to be recognized as a specialized in GTD? And what implications could this standardized definition have for global management of GTD?
Yeah, it's a very good question, and we had a lot of discussion about this. So there were 5 items where we could reach consensus on, and it took quite some time to get to these. So they are that in a center you should at least treat or discuss 5 patients with GTD. This is not a lot, but we have to start somewhere. And in many countries, there's no centralization yet. So we have to be aware of that. But we do think that at least one member of the GTD Center should be a member of an international GTD society, and also not be only member, but actually attending the meetings. The center should have an expert in experienced in giving all the different chemotherapy regimen. And they should have also access to certain disciplines and departments. They're all listed in the GCO paper, so I will not read them all out. And the center should serve at least as a regional referral center for GTD. And of course, there will be centers that do not fulfill all these criteria, but we also hope that this list will help to make steps in the right direction. And aiming for this is also good, and it can help you to get these things done and to establish a center in your own country. And if you have the center, this definition of GTD center will make it more recognizable for colleagues and for patients. And we hope that this will improve global management of GTD in the future.
Great. And I'll, as a follow-up to that, and I'll turn over to Michael, a question from 2 of our fellows, Natalia Tejeda from Barcelona, and again from Sofia Bigardi in Italy. They ask, the article notes that large-scale prospective randomized studies are lacking in GTD due to its rare occurrence, leading to differences in treatment worldwide. How do these new guidelines leverage consensus among 53 experts from 31 countries to overcome this lack of high-level evidence? What is the significance of achieving a globally agreed approach? What are the main practical strategies to overcome barriers to effective diagnosis, follow-up, and treatment?
Yeah, okay. So, I mean, it's true. We lack mostly any randomized trials in this disease setting, but I think you can look at it in a different way, and you can imagine that if you had a disease where there was 100% death rate, and you then introduce a new treatment, and suddenly you've got a 75% cure rate, do you need a randomized trial to prove that that treatment works? And I would put it to you, you don't. And in fact, it would be unethical to perform such a trial. So clearly, when it's very black and white like that, it's quite easy for people to agree that this treatment is working and we should use it. Of course, if you get into a situation where you have one treatment that cures 56% of patients and another treatment that might cure 58% of treatment in non-randomized data, clearly there's going to be great debate. Well, which treatment is better to use? Immunotherapy, for example, it's like a no-brainer. If you've got 70 to 75% of patients responding who were otherwise going to die, having failed everything else, of course you're going to use it. And if you then compare that to high-dose chemotherapy, which maybe only salvages between 20 to 40%, is horribly toxic, you don't need a randomized trial to work out what you're going to do, particularly when you take into account the cost effectiveness. One costing twice as much as the other. That's the high dose is twice as expensive as 6 months of immunotherapy. So those sorts of decisions weren't very difficult for the committee. Obviously, if you've got low-risk treatment with methotrexate or with actinomycin D, where there is an ongoing debate, although interestingly, there is a new randomized trial from China that we didn't have access to the data for at the time of our meetings, which sheds a little bit more light on this. I don't think it's going to change anything. Incidentally, it was presented at the ESGO earlier in the year. Basically, the two drugs look very similar in the low-risk disease setting. So we could achieve consensus that either was acceptable. So I think those things are important messages for the global community, because clearly you might choose one low-risk agent in one disease, one patient group in one part of the globe because it suits your clinical practice and maybe the patient cohort, whereas in another practice, the alternative single agent methotrexate might be a much more simple agent to administer. So I think we've made a lot of progress with the group in trying to decide which management profiles to follow. I think there was a second part of this question, Pedro, if I'm not mistaken. Is that right?
Yes, it was practically what are the main strategies to overcome barriers to effective diagnosis, follow-up, and treatment? And we'll touch upon those in the upcoming questions that I have for you. So we actually now we can start getting into the specifics. And I think, of course, obviously for our audience, they're going to want to know what are the latest in terms of the specifics for our patients. So I'll turn over to Christianne. And first question is, how should we come to the diagnosis and management of suspected hereditary mole?
Yeah, you say we want to know the latest, but as a doctor, you should always start with just careful history taking. And I don't think that it will ever change. So first, talk to your patient and ask symptoms and complaints. And if she tells you about vaginal blood loss, excessive vomiting and abdominal pain, yeah, you should be alarmed that there's something going on, of course. You don't have a diagnosis yet, but we obviously will make an ultrasound. This is essential, but the ultrasound will never prove that it's a mole. You always need histology. You measure an HCG, and very high levels of HCG further confirm that it might be a GTD. Then you do a suction curettage, preferably under general anesthesia with ultrasound guidance, and you should send the tissue for histology. And if you're working in an ideal setting and you have a lot of access to genetics, it would be really nice to have them performed and also store material for research. And following the procedure, you should continue measuring the HCG to see if it normalizes. And we advise to do that weekly until normalization, and then start follow-up or treat if it doesn't normalize. But I think those questions are still coming.
Excellent. So I'll turn over to Michael. This question is Lisa Prope from University Hospital in Munster. She's asking, how reliable are current histopathologic criteria in distinguishing between partial hydatidiform mole, complete mole, and hydropic miscarriage?
I think the answer to that is they're pretty reliable, actually. If you talk to a very experienced pathologist, they'll tell you that they can make nearly all of the diagnoses based on simple H&E staining of the tissue, and don't even require the ancillary techniques for most of the patients. If you have less experienced pathologists, then routine P57 KIP staining is really a must. And again, we'll sort out nearly all of the cases that they're going to see in their practice. And where there is some doubt between a partial mole, for example, versus a non-molar pregnancy loss, where P57 KIP staining is retained, then genetic analysis can be done, or there are various other ancillary approaches that can be done to sort this out. So in reality, apart from very rare cases, all of these techniques are very reliable in sorting things out for the patient.
Excellent. Christianne, what do we do in the setting of an unexplained, persistently low level, elevated beta ECG?
Yeah, we made a very nice flow diagram on this to show the different steps of attacking this clinical problem. Because unexplained lower level HCG is quite a puzzle. This first step, again, is careful history taking to learn the medical and obstetric history, and if a patient possibly takes exogenous HCG. It's rare, but it does occur. We have our cases. Then one or more ultrasounds can show whether there are signs of a pregnancy, either a good one or placental remnants. HCG should also be measured in the urine to exclude false positive serum results because of the assay interfering molecules, such as human anti-mouse antibodies. But a true positive HCG blood test requires measurement of additional tumor markers for germ cell tumors, hormones to identify menopause or pituitary HCG, and kidney function to exclude renal failure. And very rare cause of elevated HCG is familial HCG syndrome, where mutated forms of HCG are present, but they're not functional. So the only way to discover that this is going on is to measure HCG also in the parents of the patients. And if you think it might be pituitary HCG, you can treat the patients with oral contraceptives and to see if the HCG falls down. And finally, other HCG secreting tumors have to be excluded. But sometimes you do not find a cause and you just start follow-up. And that's the only thing then you can offer. But excluding all the other causes, that's really important.
Great. And I'm really glad you highlighted the flowchart diagrams in your article. And I definitely encourage all to do so and read those carefully, because they're really very, very graphically helpful. So thank you for putting those together. So this next question, I'll turn to Michael. This is from Reem Abuchakra from France. And she's asking now about twin pregnancies. She's asking, twin pregnancies with a coexisting complete mole is a unique management dilemma. How do you counsel patients about continuing versus terminating these pregnancies? And when a pregnancy is maintained, what is the monitoring protocol?
Yeah, I think this is an excellent question, and of course, it is a difficult situation. The evidence that exists suggests that it is not unsafe to let such pregnancies continue if it's a wanted pregnancy. Of course, it's a higher risk pregnancy, and so counseling of the patient is very important. So what are the risks? Well, there are increased risks of toxemia of pregnancy. So blood pressure may be poorly controlled. There's a potential risk of uterine perforation, although I think we could only find one report of that in the literature. And I can say that in the UK series of now several hundred cases, we've not had a single uterine perforation yet. There's a theoretical concern that you might end up with a higher chance of having preterm labor, and in fact the data suggests that that's exactly what you'll get, an earlier labor. There's a concern that patients might have a higher risk of developing trophoblastic tumors, but that does not seem to be borne out by the data in the literature. So your risk of having a trophoblastic tumor, if you leave the pregnancy and allow it to continue, is just the same as if you terminate it early. How should these patients be delivered and monitored during the pregnancy? Again, nobody's completely clear about this because of the increased risk of toxemia. You think that it would be sensible to measure the HCG and the urine protein and the blood pressure more frequently, because this will give you a clue as to whether the mole is growing quickly and whether it's causing problems with toxemia or not. Ultrasound might be done a bit more frequently, again, to look for molar overgrowth and to actually perhaps help you to plan the type of delivery you might wish to do. Clearly, if the mole is very low down in the uterus, then this might make you want to think about a C-section delivery rather than trying to have a normal vaginal delivery. In the UK series, about 50% of the deliveries have been by C-section and 50% by normal vaginal delivery. And I believe the median age of delivery was about 32 weeks. What's the chance of a healthy take-home baby? That's the other issue that mums would want to know. If I'm going to carry this pregnancy on, am I actually going to have a healthy baby at the end of this? And the literature is quite variable, but it looks like it could be somewhere between 30 to 60%. The latest slice of the UK data looks like it's just under 60%, which is reassuring for those women that continue. So yeah, it's a complex issue. There are no completely right or wrong answers here, and more remains to be learned.
Excellent. Thank you for that explanation. And now let's turn over to the management of the low risk gestational trophoblastic neoplasias. Christianne, can you talk us as to what is the ideal approach for these patients?
Yeah, that's a short question, but we can use the whole podcast to talk about this. So I try to be short.
I was afraid you were going to say that.
Yeah. Well, I just would want to refer everybody to the GCO article. But okay, if the ATD does not normalize and you fulfill the definition of GTN, you have to calculate a FIGO score. And if the FIGO score is less than 7, we consider the GTN to be low risk, meaning a low risk of becoming resistant to single agent therapy. You should do imaging of the lungs A chest X-ray is enough. I know that many healthcare professionals do a CT scan, which is fine, but all the data counts the number of metastases just with X-ray. So you should use that or the larger metastases to calculate your FICO score. Otherwise, it will be higher. But if there are abnormalities on your chest X-ray, you should do additional imaging, like MRI brain, MRI pelvis, CT abdo. And then you can start with single agent therapy. And we use in the Netherlands methotrexate with folinic acid rescue. So every other day the folinic acid. But there are also countries that choose actinomycin D, which is also fine because the outcomes of both therapies are excellent, close to 100%. So it depends a bit on logistics and the protocols, the national protocols, but you can use both single agent therapies for start.
Excellent. So as a follow-up to that, I'll turn over to Michael. This question comes from Mariana Carvalho Gouveia in Brazil. And she's asking both actinomycin D and methotrexate are standard options for treating low-risk GTN. In your daily practice, how do you decide between these two agents?
Well, for me, it's really dead easy, Pedro, because we use methotrexate and folinic acid. And the reason we've done this in the UK is because it means I don't have to keep bringing the patient back to a treatment center to have IV actinomycin D every 2 weeks. 90% of our methotrexate and folinic acid is delivered locally, either by our district nurse visiting in the home and giving an intramuscular injection of methotrexate, or by some other home chemotherapy delivery service. So it really keeps the patient at home and out of hospital. And so we prefer this. And in terms of toxicity, we found that the pulsed once every 2 weeks actinomycin D does cause some hair thinning and does cause a bit more in terms of myelosuppression. And nausea, they particularly feel nauseated on it, whereas we found the methotrexate and folinic acid to be in general a little bit better tolerated. I mean, it's difficult. It's horses for courses, isn't it? I mean, if you live in a world where you don't have this kind of healthcare set up, you might find that actinomycin D is a better situation for you. But for us in the UK, it's a no-brainer. And the only reason to give actinomycin D for us would be because the patient is allergic to methotrexate, or there's some other methotrexate-related issue for them.
Excellent. And Christian, this question comes from Natalia Tejeda again in Barcelona. She's asking about a second curettage. And her question specifically says, given that the guidelines state single-agent chemotherapy offers excellent outcomes for low-risk GTN, but they also mention a second curettage can be considered with a 40% cure rate. So in which specific clinical scenarios or patient profiles would you recommend considering a second curettage? And what factors would influence that decision over starting with a single agent chemotherapy?
Well, the most important factor is, of course, the patient. A second curettage is indeed an option, and shared decision making is important. I would suggest to do a second curettage if I don't have any tissue at all yet, because the patient comes from another hospital and the material was not stored, or if a patient has quite some vaginal blood loss that can stop after the second curettage. You still have to do the HCG follow-up if you do the curettage, of course, and there is a risk of endometrial scarring. So you can discuss these factors with the patient and make a decision together.
Excellent. Now let's talk a little bit about the high risk and the ultra high risk patients. And this next question is from Rema Buchakra again. She's asking, how should we manage those patients for high and ultra high GTN? Induction with low dose etoposide platinum before EMACO is recommended. how do you assess bleeding risk to decide on induction or start directly the full dose treatment? Can you elaborate a little bit about that?
Yeah, very happy to, Pedro. So the low dose EP was really designed to try and stop patients bleeding out or dying from metabolic complications because of rapid tumor collapse in response to standard dose chemotherapy in patients with advanced trophoblastic tumors. And so if you get a patient who is in the regular high risk group scoring between 7 to 12, but they have a hemorrhagic brain metastasis, starting with low dose EP would be a very smart idea, because such a patient might have a much worse bleed into their brain if you got on with regular dose Emico adjusted for the CNS, where you increase the methotrexate to 1 gram per meter squared. So that would be a perfect regular high risk patient where you should really think about low dose EP. In the ultra high risk group, these are patients you're going to find with multiple lung metastases. So their chest is often very full of lung mets. They may be respiratorily compromised, or they've got lots of metastases in the brain or the liver or both. And again, they're really at risk of bleeding complications and metabolic complications from too rapid a tumor response to the drug. So again, that's where you're going to want to use the low dose EP. So pretty much all ultra high risk patients should start on low dose EP, and a subset of the regular high risk patients may benefit from low dose EP to avoid killing them in the first 4 weeks of starting treatment.
Okay. So, Michael, I'll stay with you for this next question. And I think that there isn't a podcast that goes by without the word immunotherapy being brought up. So I was wondering if you could elaborate on how the centers might select patients for immunotherapy. What are the strategies in bringing in this type of novel therapy?
Yeah, so that's a great question. And you're right that the biomarkers like PDL1, well, they're all PDL1 positive, so you can't use that. So what about tumor mutation burden? Well, it's largely a mutational desert in trophoblastic tumors. So again, that's not going to help you select patients. Clearly, any patient you're considering for high dose chemotherapy, forget the high dose, give them immunotherapy. And I think we're going to touch on later on treatment of patients with PSTT and so on who might be considered for for high dose chemotherapy. So those would be patients where you should give them immunotherapy. Will there in the future be a selection biomarker to tell you which of those patients that you're going to give immunotherapy to will actually respond? Because it looks like it's about 3/4 will respond, 1/4 won't. And I think there is a potential for HLA-G to shine through here. So if your tumor stains positively for HLA-G, this may turn out to be a very helpful selection biomarker. And similarly, if you've got tumor infiltrating CD8 cells, then again, that might be useful to help select. But at the moment, that's still experimental. So it's going to be clinical decision making here as to who you're going to put into it. And we're talking later about salvage treatments for patients. So we'll pick up on it again there.
Excellent. So now let's turn a little bit into the even more rare conditions. And I'll start with you, Christianne. Can you tell us about atypical placental site nodules and how should we approach those?
Yes, it's indeed a very rare entity and also a rather new one, because it has first been described in 2015, and actually there are no clear definitions in the WHO yet, and pathologists are not agreeing on many of the definitions yet. We do think it's a pre-malignant lesion, but we also know that in 14% of the patients, it may develop into a PSTT or ETT or that these GTNs are present at the same time. So you have to be really careful and examine your patient well. It can also develop after the diagnosis. You should do follow-up. And we think the APSN is some kind of transitional stage between like a PSN, the placental site nodule, and the ETT or PSTT. And this is also why we advocate to do a hysterectomy if a patient does not have a child wish anymore. And if a family planning is not yet complete, you do follow up with an HCT, with hysteroscopy and physical examination. And as soon as the family is complete, we still offer a hysterectomy. If a patient does not want it, you continue the follow-up, but if she wants it, you do the hysterectomy. And sometimes even if all the follow-up was normal, you can still find APSN lesions. If you find only APSN, you can discharge the patients. If you find more, the ETT or PSTT, of course, we should consider to give adjuvant treatment depending on stage and interval and so on. We are working together, Michael and I and Leonor Koopmans and some other doctors on describing a new large series of EPSN, and this will include like 110 patients. So hopefully we learn a bit more then and can tell more about the characteristics, and also the patients. You have to be really careful with advising against or for hysterectomy.
Fantastic. So we look forward to a lot more work on that area as well. So Michael, the placental site trophoblastic tumors, what should we know about those, and how should we approach them?
Yeah, well, they probably make about 0.2% of all gestational trophoblastic disease, so it's really rare. And they're much more slow growing. They tend to produce a lot less HCG than other types of trophoblastic tumor compared to the volume of the disease. And indeed, some just don't switch on HCG production at all. They tend to involve lymph nodes a little bit more often than other trophoblastic tumors. And because they're more slow growing, they're often more confined to the uterus. So they often present with uterine disease rather than widespread metastasis. The problem with this disease is that it is a bit less sensitive to the chemotherapeutic agents we have. It's not resistant to them, but it's a bit less sensitive. And because of that, you can't start treating them with single agent treatment, so they can't be put through the scoring system. Instead, we use the FIGO staging system to assess their spread. And the key prognostic factors for them is the interval from the time of the end of the causative or preceding pregnancy to the time at which they present. And if you catch them within 4 years of that interval, then the outlook is usually very good, even if they've spread a little bit from the womb. Whereas if they present more than 4 years out, then the outlook, even if they've got stage 1 disease, is much worse. And in fact, in our first analysis that we published back in 2009, every single patient presenting like this eventually died. They may have responded to some of the treatments that we offered, but they eventually died. So the other key independent prognostic factor is stage 4 disease. So if you present with stage 4, that's definitely not such good news. So what have we learned? Well, we've now learned that anybody presenting with very advanced disease or presenting with very long interval disease is going to need very aggressive management beyond just the surgery to remove the primary site. And that aggressive management has been prior to immunotherapy in the form of platinum-based chemotherapies like EPEMA or TETP, followed by tandem high-dose chemotherapy, Now that we have immunotherapy, the high dose chemotherapy has been thrown out and replaced with immunotherapy. And in the latest analysis that is not part of our guidelines here, but is now submitted for publication, it looks like we have, with immunotherapy, pushed the survival rate up closer to about 70 to 80% in these poor risk patients compared to having had a 0% survival in the past. So that's pretty impressive, but there's still some room for further improvement. I think I'll stop there.
That's definitely a positive outlook with the immunotherapy. So thank you for sharing that. And Christianne, I'll turn to you for this last question on the rare entities. What do we need to know about epithelioid trophoblastic tumors?
Well, the diagnostics and treatment of ETT overlaps with PSTT. So the things Michael said about PSTT for a large part also count for the ETTs. It's also a rare tumor from the intermediate trophoblast. It's more aggressive than PSTT, but in both tumors, surgery is the cornerstone. And ETT often is found in the lower part of the uterus, sometimes really mimicking and cervical cancer. So if it's there, you have to be aware that it can also grow in the perimetrium, and you should maybe do a radical hysterectomy instead of a simple hysterectomy if you think that might be there, because you should not leave disease behind, because it's less sensitive to chemotherapy and more difficult to treat if there's remaining disease. And also for ETT, the 48 months or the 4 years that Michael talked about in PSTT, this is also a poor prognostic factor, and you should give patients more and longer treatment if they present with such a poor prognostic tumor.
And now, Christianne, let's turn to surveillance. What are some of the highlights that you would like to share with our audience as it pertains to actual surveillance of these tumors?
Yeah, well, if you're talking about surveillance in general, you should, of course, follow the guidance of your local GTD center, because there are differences between countries and between possibilities between countries. But of course, it depends strongly on what type of GTD your patient had. We provide nice flow diagrams for all these follow-up in the guidelines. And we actually hope that they will be transferred to an app. So as a doctor, you can have them close by and just see for your patient with the type of GTD she has what the optimal follow-up is. But we have to say that, like for PSTT and ETD, we are flying a bit blind, because there is not good literature on what's the optimal follow-up and how often should you do that, and should you use imaging every time. So with consensus, we try to come up with some suggestions. But, well, referring back to the questions, do we have a lot of RCTs? No, and certainly not for follow-up. So you should discuss it with your patients and your local GTD center, but we just try to hand out a bit of guidance there. And we hope that in the future we do have more data on optimal follow-up. We do know, and that's quite a new article published, that the follow-up after complete hereditary mole, like in partial hereditary mole, could be stopped after normalization of the HCG and confirmation of that normalization, because the risk of recurrence is really, really low. And there might be patients that prefer just to continue a little bit with the follow-up, but recurrence rates are below 1%. So if your patient wants to get pregnant, I think we shouldn't be too strict in telling her to wait.
Mm-hmm. Great. So now let's get on to the patient population that recurs. And Michael, I'll ask you, with recurrence of disease, what should be our first go-to treatment for these patients?
Yeah, well, I guess recurrence can happen after low-risk treatment. So you may have been treated just with one single agent, or you may have been treated with one and then a sequential single agent. So for low risk disease like that recurs, I mean, the first thing to do is obviously to properly stage the patient with extensive imaging. And if there is no metastatic disease, maybe there's just an isolated lesion, then you could consider surgery as the simplest thing to do to remove it and cure the patient. So that would be a great option. But obviously, if the disease is, for example, in the womb and patients want to retain their fertility, as they frequently do, then you're going to need to give them some further chemotherapy. And if you've failed one single agent, many centres agreed that they would like to give them combination agent chemotherapy rather than risk another single agent and have them relapse again. But there are some centres in the world that didn't feel they liked to do that and would want to give the second single agent instead. And we agreed that there is a lack of evidence to support which of those things would be the right approach. And so that's an ongoing topic of research for the international group to address. Obviously, if you'd failed two single agents, there'd be no point in doing anything other than giving combination agent chemotherapy. So that, I think, deals with the low risk group of relapses. In the regular high risk group, so those treated with EMA-CO, then the same principle. If you've got something surgically resectable, why don't you try and do that first? But if you don't, or there's a desire to retain fertility, then it would be very reasonable to give platinum-based chemotherapy as the next line of treatment, which would either be TETP or EPEMA, or if you're in China, they prefer the FAEV regime. And again, details of all of this are in the article. If we then come to the ultra high risk, well, it's the same situation again. What should you do? Surgically resectable, fabulous. If it isn't surgically resectable, then you're looking at perhaps giving them immunotherapy, because this looks just so very effective, rather than proceeding down the lines of trying to give them high dose chemotherapy. Further details on all of this are in the manuscript, and so probably we don't need to get bogged down in much more at this point. So hope that gives you a good synopsis.
Great. So I just have a couple of questions for you, and I want to be respectful of your time. This question I'll ask Christianne is from Frederick Strosch in Heidelberg University Hospital, and she's asking, which recommendations showed the greatest discrepancy within your expert panel, and which aspects were revisited during the review process?
Yeah, I like this question. And it's also nice that the questions come from all over the world. So I think we had the most discussion about the definition of a GTD center. I think we started in the beginning discussing, should we have a definition for GTD center? Then we agreed we should have one. But then what should be the definition then exactly? That was quite a hard job. So I think that's that's the most discussion. Well, let me say that again. That's the that took the most time and the most discussion of all the things. I think other items that we did not completely agree on were the frequencies of follow-up, for example, for complete EOTTD4 mole. Also the role of immunotherapy, so when to give it in the process and which agent to give. And probably finally, the number of consolidation courses in low-risk disease. Because there is some data, but not everybody agrees on this data, because the groups are not completely comparable, but we do not have anything better. So some countries give 2 courses, other countries give 3 courses, and outcome is very good in all countries. So this is something for the next guidelines, probably.
Excellent. So that's actually a perfect segue to my last question to Michael. This comes from Helena Obermeyer in Sydney, Australia. And she's asking, you emphasize the importance of referring to and involving GTD centers. Has there been any evidence that demonstrates the benefits of centralization of care for these patients?
Funnily enough, Pedro, there has been, yes. So from the United States itself, dear old Ernie Cohorn did a little study looking at the survival of patients inside specialist centers that used to exist in the United States, and now they're vanishingly rare, compared to survival of patients not managed in specialized centers. And there was a very stark difference. So I noticed that there was a recent publication, I think, in Gynae Onc from New York, from the Memorial Sloan Kettering Group, showing a rather similar experience again in the United States. And there are other examples of showing that for rare diseases, having care centralized and in specialized centers has a large impact on the outcomes for patients. So testicular cancer is another example where this has been shown. So it's a bit of a no-brainer, really. If you are a doctor seeing a patient once every 5 years with a particular disease, you're never going to get very good at it. Whereas if you're seeing 100 cases a year, you're going to get much better at it. And I know if I'm going to go and have my hip replacement at some point in my life, I'm not going to see a surgeon who does one operation every month. I'm going to go and see a surgeon that does a couple of thousand a year.
Excellent. Christianne, Michael, thank you so much. I feel so lucky and fortunate to have had the discussion with both of you. I've really learned a great deal. Again, I'm a huge advocate of this article, and I've sent it out to so many, and including our residents and our GYN oncology team here at Houston Methodist. I want to congratulate you both and all of the other co-authors for what I'm sure was a massive effort and a massive coordinating for all of them to get together and provide their expertise. So thank you to all of the co-authors, but particularly also to both of you for accepting the invitation to discuss this article with me and for the contributions you have made and continue to make in GYN oncology. Thank you.
Okay.
Well, thank you for the invitation. It was a real pleasure.
Yeah. Nice to see you. See you on Friday.